Hello, happy Event Wednesday, everyone. I'm Shernay Williams, Events Manager for Word in Black, where we have a virtual conversation like this at least twice a month. Tonight, we're talking about maternal health and solutions for what is really a health crisis in the Black community. I want to give you a little bit of a background on Word in Black. We're a national news and research organization dedicated to encouraging in-depth conversations and understanding in the Black community around topics that include health, religion, and education. And like I said in the beginning, roughly every other Wednesday, we're hosting an event on a topic like this, one that impacts the community and allows for deeper analysis beyond the headlines. And we have some great headlines as well at wordinblack.com. And these events are brought to you by the Knight Foundation. Knight is a nonpartisan and community-centered organization that promotes a healthy and engaged democracy. Our conversation is titled Delivering Solutions for the Maternal Health Crisis. And so our moderator for this conversation has been reporting on maternal health extensively. Jennifer Porter Gore is Word in Black's health correspondent, so she's the perfect person to have for this conversation. I'm going to invite her on stage right now. Hello, hello.
Hi, Shernay. Hi,
Hi.
everyone.
So a little background on Jennifer. Jennifer is a writer based in the Washington, D.C. area. She's a former political and strategic communications professional who has worked for elected officials, political candidates, and trade associations. Her writing has been published in many publications, including the Washington Post and the New York Times. And for Word in Black, she covers all aspects of public health and well-being, including maternal health, mental health, gun violence, and health disparities. So thank you, Jennifer.
Thanks for having me.
Yes. And so you have been working on this maternal health series for a while now. You've already written several stories. Just tell us what draws you to this topic of maternal health.
Well, first of all, thanks for having me again. And I thank everyone for attending because obviously maternal health is a crucial topic. Everyone has a mother. So when we see that having children becomes difficult, especially for people who look like us, there's a reason that is occurring. Everyone, including medical professionals and academic researchers of all levels, everyone agrees that it is not because of physical differences or there is no biological reason this is the case. So there is a policy reason and there are, practices that occur that are causing this issue. And I think that it's important and we need to see what we can do to fix it.
Yes, very important. And you, like I said, you've been releasing stories so far. Can you tell us a little bit about what you've come across?
Yeah, well, first of all, I've come across people who are committed to this, to the solutions, and of course, I've seen just how intractable the issue is. It's a longstanding issue. It's in the United States, obviously, is rooted in slavery and oppression, and I do see though that as is usual, Black Americans are not just sitting back and letting it happen. So I've come across people who have put together all kinds of solutions for all types of audiences. And I'm glad that we have some of them here today.
Yes, very exciting. And so I look forward to hearing more about those stories that you've written and the ones that we have coming up. But I want to get this conversation going because we have some great panelists, like you said. So, Jennifer, I will let you take it away.
All right. Thank you. All right. Yes. As Shernay said, we do have three great panelists today, and I just want to go ahead and introduce them, bring them on camera. We have Dr. Katura Felix, who is a distinguished scholar at Johns Hopkins University and also the host of the Deep Care podcast. We have Kay Matthews, who is founder and executive director of the Shades of Blue Project in Houston. And we also have Tamara Mason, who is director of Maternal and Child Health Collective Impact with the March of Dimes. She's the director of that program. So I think what we're going to do is start with our first round of questions here. I'm going to pull up and ask Dr. Felix. We wrote about you a couple of weeks ago, and I wanted to talk about what prompted you to pursue your research on Black midwives and doulas who are working in Black communities.
Yeah, thank you so much, Jennifer. It was a beautiful piece, and I'm really happy to be here. Welcome, everybody. And so I'm, like Jennifer said, everybody has a mother. I don't only have a mother, I am a mother. And I have lived in the United States for about 40 years. And in the late 2000s, I was hearing a lot about the Black women dying. And there was a lot of conversation in the press. The statistics were there. But then when I went back to Dominica, where I was born, Black women weren't dying. And so that piqued my interest. What was happening here? Now, Black Americans and people outside the Caribbean, same genetic pool in the sense of coming out of enslavement from the continent of Africa. So I knew it was not genetics. I knew it wasn't biological. I'm also a physician. And although I did not experience, at that time when I did this research, I did not experience what you would call medical racism. I experienced racism in the workplace. And knowing how these systems work, I knew that there had to be racism in the medical establishment. And so the question I asked myself is, what is the Black community doing about the Black maternal health crisis? Right? We were hearing the statistics, but we were not hearing the solution. And so in 2023, I picked up the telephone and spoke with 70 experts. And they said to me, look to Black community midwives. Some of them also mentioned doulas, but they said, look to Black community midwives. The other thing I also want to say is that, I birthed in the United States. I had elevated blood pressure, but I did not have preeclampsia. And knowing what I know right now, had I been born in the United States and given my pregnancy experience, there was no doubt in my mind that I would have had preeclampsia or bad outcomes. I have a daughter. She has all the risk. She's grown up in the United States, unlike me, right? I came here when I was 19. So she faces those risks. So that empowered me, knowing my experience, knowing my daughter and all that generation really energized me to look for a solution. And I chose to look for a solution in the community. So although we weren't hearing about the solutions on the news, I knew there had to be solutions. Because Black people, right? People, when we love our people, we never leave them to their problems. We always try to solve the problems. And when I spoke with these 70 experts, they told me, look to Black community midwives. And I was shocked. Here I am, a physician, a mother, midwives. I thought that was something of the past. And so I designed a study to do that. The first thing I did was that even before designing the study, I said, I want to see what these people are saying. Like, why don't I know about midwives, community midwives? So I jumped on a plane, went to LA, and I observed a midwife. And I observed her on 2 different visits. And Jennifer, friends, what I saw blew me away. And I thought, is that just, the odd case here? And so I designed a study to really go deep into community midwifery.
Okay.
And right? I mean, we'll talk about that later.
I can't wait to, I'm really excited for us to get into what you found. Now, Tamara, I'm going to turn to you because, of course, Atlanta, where you are based, Georgia has some of the highest maternal mortality rates in the country, Atlanta even more so. And that's especially true with the stark racial disparities there. So from a public health data perspective, what are the leading contributors to that gap in Atlanta specifically? What are you finding? And how is March of Dimes, just give me a little intro here to what March of Dimes is doing about that.
Yes, thank you. Thank you, Jennifer and Word in Black, for inviting me to this really important conversation. Excited to be here with Dr. Felix and Miss Matthews, who I admire both of their work. And Dr. Felix, I was like, I know you're Caribbean. I'm Jamaican originally. And I was like, the accent is not Jamaican, but okay, Dominica, I'll accept that. I've actually been to your country. It's a beautiful country. So as mentioned, my name is Tamara Mason. I work for the March of Dimes here in Atlanta, Georgia. March of Dimes, as you may know, is a national organization. We're a large maternal and child health nonprofit, actually one of the largest and oldest in the country. And our entire premise is that we think every single mom should be able to have a healthy pregnancy, and every baby, regardless of race, regardless of where you live, should also be born full term at 37 weeks. And something that I'm really proud of to work for March of Dimes during this time is something that we're calling out why we're not able to achieve these outcomes for all of our moms and babies is because of structural racism and the fact that we have to close the health equity gap in order for every mom to have a healthy pregnancy and every baby to be born healthy and strong.
So just wanted to put that out there about March of Dimes. So here in Atlanta, which is my adopted city, I have been here for 25 years now next month. So obviously that means I moved here when I was 5 years old. And I love Atlanta. I love Georgia. Atlanta is its own version of Wakanda, right? So much Black excellence here. Unfortunately, though, Atlanta is also a tale of two cities. Atlanta is the #1 income inequality city in the country. So if you are born in poverty here in Atlanta, you only have a 4% chance of moving out of poverty. And who is in poverty? Black women of reproductive age, right? So I give that background in the Tale of Two Cities because structural racism are social determinants of health like poverty. I always say that pregnant women do not live in a vacuum. So if we have a mom that is poor, if we have a mom who's food insecure, who's housing insecure, all of these outcomes are going to impact her pregnancy journey. It's going to impact her birth. So that's something here that we are talking about a lot more, and I'm glad that we are, but it's definitely one of the root causes of the issues that we see. And then also just access to care. And I know that sounds like very simple, but here in Georgia, about 40% of our counties, we have about 159 counties in the state of Georgia, are considered maternity care deserts. And so if you're in a maternity care desert, that means that you do not have the access that you need for the OB and GYN care. So that's 40% of our counties. And that's even happening here in Atlanta in an urban city. Like if you live in Atlanta, there's a whole thing of North Fulton versus South Fulton. If I live in North Fulton, which is where the city of Atlanta is, I have access to a lot of other resources that I don't have in South Fulton. So to me, those are the top three that are driving, unfortunately, the disparities that we see: structural racism, that health equity gap, these social determinants of health, and then also our lack of access to quality and culturally competent care, even in this great city of Atlanta, aka Wakanda.
Yeah. Yeah, it's kind of bracing too that when you think of Atlanta and you think of first of all, when you think of the US, we're supposedly so technologically advanced, and yet we're the ones on the world stage who have this problem the worst. And I think that what you mentioned about the social determinants of health, people forget that this affects the mental health of the mother as well. And that's why I'm going to turn to Kay Matthews, who founded Shades of Blue in Houston. I would love to know what made you found that and what made you start the Black Maternal Mental Health Week observance.
So, first and foremost, I would always lead with this work chose me. I did not choose it. Unfortunately, I am on the mortality side of it where my daughter was born still. It was also the very first time that I experienced racism being a Black woman in the healthcare system. It was the turning point because life changed for me after that experience in so many different ways. But first and foremost, my mental health is what had me out here saving myself. That is no way to live. It was a real true commitment that I made to myself that when I got better, that I would let others know about it. And that's how the Shades of Blue Project came about. I've always been centered around community in my prior lifetime. I'm on my fourth one. In my prior lifetime, I was a chef. So if I couldn't do anything else, I could cook you something to eat, make you feel good, right? So it's the same extension of I was no longer a chef. That's something that I retired from, but I knew how to bring people in, give them information, make them feel good, make them feel well. So I always been centered on mental health. And when mine was challenged in a way that I did not know how to help myself, that really impacted me. So I felt like I struggled for an immensely long time because there was no correlation being made to infant loss and postpartum depression, which I was clearly going through. The saddest part about my story will always be for me is that I did have to save myself with no guidance. Just simply asking people to listen to me. So it is the one thing that we lead with within the organization is we ask two questions. Do you want us to just listen or do you want us to listen and respond? Because sometimes people just need to get that out there so you can help them to navigate what it is that they need. And because overall it was my mental health that people were not concerned about, it became my focus. So creating Black Maternal Mental Health Week is me looking at, okay, I've been sharing my story. People have been sharing their stories. Now everyone has a story that they didn't even know that they could share or that anybody even cared about once I started talking, right? But how could we take this further? So the creation of Black Maternal Mental Health Week for me was a way to continue the conversation. So we have the hashtag, the conversation continues, because even when we get off this call today, we want people to keep talking and keep sharing. So that's the basis of Black Maternal Mental Health Week. The other precursor to creating Black Maternal Mental Health Week, I do not want it to exist 20 years from now. I want us to have gotten it together where we do not have to have conversations like this because women are truly dying 365 days after giving birth. That's a success. Day 366 is a successful birth here in the not so great state of Texas. Also, Harris County is one of the deadliest places for Black women to give birth in this city alone. So that tells you a lot of what you need to know. And I am smack dab in the middle of Harris County right now as I sit here having this conversation with y'all. So I lead with the fact that I am the community that I serve. I am not exempt from any experience, right? And the understanding that ties me to this work continues to drive me because I have been on the other side of someone's desk who simply said, "You make 73 cents too much to get temporary support." And so I simply wanted to change a lot of systems that I experienced in something that was short term because I saved myself, but it could have been long term if I didn't have the willpower to save myself.
Yeah. So now let's talk about how, first of all, thank you, because that was a courageous step you made. And obviously it's having long term impact. So let's talk about how each of you is working in the communities, because obviously you're each tied closely and you're seeing how community is coming up with solutions. So, Kay, I think I'm going to ask you first. With most mental health conditions, postpartum depression is undiagnosed or misdiagnosed in Black women. So, how does your organization identify and reach women who might go unscreened or untreated otherwise?
So we don't have a one size fits all approach. We serve the person that is presenting in front of us. Something can feel similar, right? But it's not the same. So then, therefore, we have these true conversations around what the needs are, and how do we help support you. So we are a social support service organization. So we give free diapers, wipes, clothing. Our mental health support is free. We can get you connected with a therapist and cover the cost of that for 6 months through our relationship with BetterHelp. Understanding what resources are out there too, and understanding that everybody doesn't learn in the same way. So how I tell you numbers, maybe you need to hear the numbers and the data, but maybe the other person needs that broken down in a different way. But we truly have identified who we are in this space, and that's 5% of someone's healing, and that's resources. We are going to make sure that we are not just telling you what Google told us, that we have a connection at the place that we're sending you. We call them for you so we don't send you down there. All of these different steps that we know to be barriers because we listened to what community has told us. And we want to do the opposite of what their experiences are, because experiences, again, with social support services, like I experienced the 73-cent thing, I'll never have someone sit across my desk and need diapers, because diapers start right now at about $25 a case and up. To need diapers or to have basic needs and be told that a requirement of something you just may be having a hard time, right? Like we all run into something. So removing all barriers from care is how we center community as well. We collect the information around like what your income is so that we can, again, furthermore show you can just have a bad month or a bad couple of months and be able to get back on your feet if you had a little bit of support that was centered around you and what your needs were. Even if we are not the person that can provide them, we have someone within our network, which is that's what we stand on, being trusted in community. Because when they come to us, they'll never have to look too far for us. We've been here, but when they come to us, they trust that we are leading them in the right way. And so that not just being trusted, but being a leader in the space is also important because somebody is depending on you to be able to help them navigate what it is they need. And so us being truly committed to being a resource for what it is that you need helps us continue to stay centered to community because that's the only way we'll be able to continue to do this.
Yes, thank you so much. I'm noticing I can tell that there's going to be a trend here of working with the whole person, treating the whole person. So, Dr. Felix, let's talk about that. I see you got the snaps up going there, Katura. Let's talk about what you've seen, how midwives are treating the whole person, because that seems to echo what Kay was just saying.
I really appreciate what Kay and Tamara said. A couple of things. One, around the postpartum period and the depression. I had depression when I was pregnant. We didn't have a name for it. It's just that I felt so bad and so alone during that time. Fortunately, I worked myself out. I just got busy with life. So basically the functioning depressed person that we have a lot in our community. Piece I also want to lift up is what Tamara talked about, the social determinants of health. And it's really important that we understand that the social determinants of health is not just about housing. It's not out there. It actually affects our bodies because social determinants of health are exposures, toxic exposures that we and Black people get, and that translates to weathering. So when we did the Black, our study, we were told that look to Black midwives. And I told you I went to LA and I was on a postpartum visit, and that just blew my mind. I saw a midwife. I went on 2 visits. And of course, all the clinical things happened, but there was a lot of conversation about support. The first visit was a 10-day visit. The entire visit happened on the bed. I was like, I had never seen anything like that before, right? Because the midwife was committed to supporting the mom, getting her staying in bed, repair, rest. The conversation also was about support and coaching. Who is supporting you? Who is bringing you food? What are you doing? What are you feeling, right? And that was amazing to me. The other postpartum visit was a 10-week postpartum visit. Still focused on support, but the focus here was on support to help the mom re-engage with her life, get back into life, right? So that is where we see a focus on support. And we called our study, based on that, we called our study the Black Birthing Future Study, because we were interested in what the Black community was doing to take us to the future. And I think that's really important. And what we saw, we interviewed about a total of 114 people. We interviewed midwives, we observed midwives, interviewed their providers, their partners, doulas, mental health therapists, community organizations like Kay's organizations like that. So we really got a comprehensive look at what Black midwives were doing in the community. And what we saw, they provided comprehensive care, holistic care. Client after client after client told us, my midwife loves me. And that is not just a nice to have, that's a game changer. Because one of the things we've learned, and we know about weathering, but I don't think we translate. Weathering isn't something that's in the air, it's in our bodies. So what we have is that Black women in America, Black birthing people, enter pregnancy with their body already at capacity. Too much pressure on the body. And because pregnancy is a stress test, that's what it is. You are growing a whole human being. With that stress test, the organs can decompensate. So one of the Black midwives said to me, and that's what really got me on this journey around looking at stress and what it means. She says, think of it, many Black women, pregnant Black women, they are running a marathon right fighting a war. That is just too much. And I think the medical establishment don't appreciate that. Midwives appreciate that. Doulas appreciate that. And so they give the pregnant person an opportunity to take some of that load off. One of the things midwives do is a new mom, a new pregnant person, nervous, anxious, they're hearing the statistics too. One of the midwives said, and one of the clients said, she gave me the last appointment of the day so that I could answer all my questions. Imagine that, what it does, the pressure that is relieved around pregnancy.
Yeah,
Well,
just the
that's
ability
these are
to
the
ask
things we
those questions.
see.
Yeah,
Absolutely.
I mean, because like what you're saying, the body, if this isn't happening in a vacuum, the
No.
person just walking around with nothing else to do but be pregnant. That's bad. That's stressful enough. The pregnant mother is also working or looking to work or taking care of a home or could be taking care of other children because it's not her first pregnancy or there are lots of stressors. And I think that what you all are hitting on regarding the body and also the outside stressors, I kind of want to go to Tamara right now and ask her about what the March of Dimes found in Atlanta with your collective impact program and also your pilot, which I don't know how much you can talk about right now, but it seems like it's talking about is working on some of those social determinants that can really make the difference.
Yeah, thank you, Jennifer. I can talk all day about that guaranteed basic income pilot, which I will get to. But I wanted to piggyback off of a couple of things that both Dr. Felix and Kay have said. First of all, I'm a doula. I'm a certified labor doula. So I am always partial to other people in the maternal health workforce. Like, of course, we know our physicians are important, but the midwives that Dr. Felix is talking about, doulas, community health workers, we're really important as well. I'm not saying that we're the end all to the be all, but we have to have, these other support people as a part of the system, as a part of your team. So I just wanted to put that out there. But in terms of your question about March of Dimes and the collective impact. So as I mentioned, March of Dimes is a national organization. And so some people may be familiar, with some of our national programs, whether it's via advocacy, research, or direct service programs like our NICU family support program, group-based prenatal care. But collective impact, which is what I'm doing here in Atlanta, I love collective impact for two reasons. The first reason is that it is place-based. It is very specific to where you are. So, Kay mentioned that she's in Harris County in Texas. I actually have a colleague with the March of Dimes, Alicia Lee, who she's doing collective impact specifically in Harris County. I'm doing it here in Atlanta specifically for Fulton County. And why that's important is because even though, yes, this is a national issue, we're sort of talking about it on the national scale, and some solutions can apply across the board. But I think really if we're going to move the needle forward, for lack of a better word, in this crisis, right? We have to get hyper localized, but with the big funding, if that makes sense, right? But you have to do what works in your community. And that's both what Dr. Felix and Kay have been saying, right? And another important thing about collective impact is that we understand that this large social scale issue of reducing inequities in maternal and infant health, no one organization can do it alone. Not the March of Dimes, not other organizations. If we were, we would have done it, right? Like March of Dimes is almost 90 years old. We eradicated polio. We would have eradicated this. So I think that's really an important and critical piece about collective impact. It's that it realizes that it's going to take everybody, not just the folks in maternal and child health, but all the folks that we talked about in the social determinants of health spaces, our healthcare organizations, but also the community, the moms. People with lived experience. So that's something that is really, really important about collective impact that I think we have to mention, and that as I've learned it honestly on the job at March of Dimes, I'm like, oh yes, this is all the difference, right? So one of the things with collective impact, it's a very iterative process, which I've also learned, and you have a common agenda that all of us as organizations we've agreed to. So here, our common agenda in Atlanta, full stop, is that we want all Black mothers, birthing people, and families to have positive outcomes before, during, and after pregnancy. Sounds very simple, right? And we say that we're going to do that by dismantling racism. So I always joke around and say, when we dismantle racism, I will win the Nobel Peace Prize. We want to increase access to equitable and affordable care, and we want to build connected and economically viable communities. And so in each of those solutions, we have projects that are happening. And so one that Jennifer referred to that I'm really proud of and are building economic and sustainable connected communities is a guaranteed basic income pilot program. Guaranteed basic income, the idea was actually posited by Dr. King, so a son of Atlanta. And the whole premise is that he started talking about this in the 1960s. Back then, you give poor people money, period. Give them money to start to pull themselves out of poverty, And poor people know what to do, right? They know how to budget. You don't have to talk to them about budgeting. Like, they're making it happen. But if you give them money, they can start to move into a better economic situation. And so that idea has actually started to move over to the maternal and child health space and other spaces as well. And our program, I always have to give credit to a program in California, San Francisco called the Abundant Birth Project. They were sort of one of the first like guaranteed basic income programs for pregnant moms. Ours is very heavily modeled after theirs. And so with our program, we were able to give us a small pilot on 25 pregnant women, $1,000 a month for an entire year. So $12,000 for these women. And they lived in 2 zip codes in Atlanta with really high rates of preterm birth. So, the premise is that we know we're not going to be able to make a change in that indicator in 1 year. But if we start there, right, that's the gold standard, high rates of preterm birth. If we start to reduce the stress and strain of these moms, then eventually they will have better birthing outcomes. But in addition to the money, and this goes back to like collective impact and the partners in your community here in Atlanta, there's a wonderful organization. I always hype them up called the Center for Black Women's Wellness. They have been in this work for like 35 years, right? So they were one of the main partners with this guaranteed basic income program. Another organization which some of us may be familiar with, for Care for Moms and Helping Mamas, that's just here in Atlanta. They were giving diapers and wipes. So say all of that to say, right, it just wasn't March of Dimes. We had to have these community-based partners who were doing all the other things to make this program amazing. So March of Dimes, i.e. me, yes, I secured the money, almost $500,000, so the women can get that stipend, but everyone else did everything else. Helping Mamas gave these women 300 diapers every month and 8 packs of wipes. Anyone with kids out there, y'all know how expensive, Kay already mentioned it, how expensive diapers are, right? So they were getting that. They were also getting connected to doula referral agencies. Now they had to take the initiative and take that step further to actually, call and make that connection. But at least that resource was there. We talked about resources and just so many other things that we March of Dimes we couldn't do alone. So really proud of that program. And that program just ended a couple of weeks ago on June 27th. Emory University is our evaluation partner. As a public health professional, I know I have to have evaluation. So I'm excited to see, the final results from that evaluation at the end of next month, August. And then hopefully we can scale this program. Yeah. So that's collective impact in action in Atlanta. And that's just one of our solutions.
Yeah, I think that that's a powerful solution, and I can't wait to see the final data because I suspect, and I'm just going to ask Kay and Dr. Felix, Kay, let's talk about what you see. You mentioned earlier the 73 cents. I'm guessing you mentioned, that the person made just a little over per hour to not get some type of government support. How often do you see that financial issues are really causing, a big strain and actually impacting the mother?
The financial part of it is always going to be a driver. This is why you have to know in order to serve people what they have going on. And typically, it's not what they have going on for themselves. It's everybody else around them that they are concerned about before they are concerned about themselves, which is why I always say people don't want to come to support groups until they get the support that they need. And maybe they will come to a support group, but they're not running to go into a support group when they still have to pay their rent.
Now, wait a minute. Say a little bit more about that because you would think that the person would come in, they're going to a support group because they need support. You're saying they have to.
Because they are centering themselves, and how often do we slow down to center ourselves? That's the driver for me in this work. So I don't do a lot of the things that take me away from rest because it has already cost me something, right? So I've already paid a price where rest was at the back instead of the front. So when I'm rested, I'm my best self. When I'm not, right? We use a lot of like proverbial like cliches and things like, don't give from an empty cup. No, only give from your overflow and you don't have to worry about an empty cup. It's really shifting the mindset. And in order for that to happen, you really do have to have this clear driver on mental health and what its impact is. But no, we didn't have large numbers of folks enrolling in the support groups outright. They knew we offered them, and we were going to be there if they showed up or if they didn't, but it's not what they necessarily are coming to us for. They're coming to us for support. And we have to be able to decipher what that actually looks like for them, not just what we want to see. Yes, I want everybody in a support group, but let's be honest, everybody doesn't need a support group. Everybody doesn't need therapy. There are things that people need that will help them be in the fight with you. So sometimes we're fighting for people without them. And that's not what that's never what I want to do. I want you to be in this with me so you feel accomplished, because I can't fight harder for you than you are able to do for yourself. So it's not about what we want as an organization. Again, knowing what our role is and why we're here is what we do. And when we need to go outside of that, again, that's case by case, because we are looking at the person that presents in front of us. But we never overpromise. We deliver what it is that we say we can do, but we do have a network of others who could probably fill in the gaps of the things that we do not do or we don't offer. But no, being realistic about how you serve people and how people want to be served. And the honestly thing is, no one was running to our support groups until we started saying, we'll give you diapers and wipes if you come to a support group and center yourself. And then it's like, well, I guess, because guess what? They really needed those diapers and wipes. The other part of that is we would have given them the diapers and wipes, whether they committed to the support group. But it's a buy-in. That's the buy-in. We're going to give you this, and you're going to give us this, because mental health is our focus. It's not an and or part of our conversation. Like, we don't leave mental health out of anything that we do. And that's also a part of the work that we are centered around, is not having mental health be and or. It is maternal health. So mental health is a part of maternal health. Just want that to be like the norm, right?
Right.
Not like a afterthought or something we think about second, because most folks are struggling mentally in that maternal health, whether it's while they're pregnant, postpartum, 5 years from now, 20 years from now. I run across lots of women who said, I wish we had services like this when I was, pregnant and things like that. Or people who say, I wish I had services like this. And I'm like, well, how long ago did you have your child? They're like 3 years ago. And I was like, but we existed. And so how do we do a better job of even that? For me, this thing is coming down to accountability. Data is, I like to take the data and put it into the real numbers where people understand that I'm talking about your sister, your cousin, your auntie, somebody, a woman in your family, your girlfriend, someone close to you is that data. Those numbers are talking about family. They're talking about friends and what that means. So we actually are going to be releasing our state of Black maternal mental health 10-year report. I've been putting this report out every 2 years, and this is our 10th year, where if we don't land into accountability, a year from now, 365 days from next Friday, this thing will be 10 times worse in just a year's time. We have to be real about what is happening on our watch, because we're out here, right? And we're doing this work. But it lends back to what Tamara said about collective effort that moves the needle, not just to say we worked on this together, but what did we work on together that moves the needle? Because we don't have to look for solutions. The community has them. Community-based organizations have. The solutions are here. What we need is funding is one thing to back solutions, but that collective effort supersedes funding in so many different ways. We need the funding. I'm not crazy. I run a whole nonprofit over here. We need the funding. I'm not saying that. But the collective effort that it will also take, because I never want to do all the things. It's not my goal. It's never my goal. So this thing that we are tackling, we're tackling it from this lens of this is what we're great at, and we can help assist in the other ways, right? But what does collective effort that moves the needle actually look like? Being committed to ourselves first and foremost, because we are who we put on the back burner, but we're the ones that's fighting the fight. So why is it that we are second to anything? I'm not. That's not the behavior that I practice. I'm first, because this is the only way I'm going to be able to do this work. This is the only way I'm also going to be able to listen to what people are simply telling us, the simplest things. Like Ms. K, you don't have to have 10 programs for us to come and get support from the Shades of Blue Project. We have 2, and they effectively work, and we make adjustments based on our community. So that's like the big picture lens of this collective effort. that I feel like is missing, but it's needed. It's like that piece, that one little puzzle after you done put that 1,000 piece together, that one piece that you can't find, it's been there the whole time. We just need to put it where it needs to go and then make it happen.
Yeah, so, that's a good analogy. I just want to kind of ask, Dr. Felix, how do you see midwives putting themselves in the picture, acting as as the puzzle piece that like Kay is mentioning?
Yeah.
Based on your research, it seems like they are doing that. How are people finding midwives and doulas? How are midwives finding patients, clients? How are they making those connections and coming to solutions?
Midwives are operating at many different levels, right? So they are taking care of their clients one-on-one, helping their clients with their medical care that clients say is really important to them, right? Clients say that these midwives love me. I have all this stress, and when I go in, I can put my burden down. So that's one. Midwives they also see pregnancy as a community and family event. So many in medicine, many people think that you are the pregnant person, it's your burden to bear, but the midwifery model of care looks broader than that. And the midwives are integrating family members. They're asking your auntie and your grandma to come support and relieve the burden that the person is doing. They're addressing financial burdens. Financial stress is huge on pregnant people, right? And one of the things these midwives do, although most insurance does not cover midwifery care, all the midwives I worked with provide payment plans for their clients. The cost of midwifery is anywhere between $4,000 and $8,000. That's all out of pocket. So they have these plans where people can pay into the care. That is really important as well. They're looking to have collaborations. So what my research saw was that in community, these midwives aren't just working by themselves. They're working with doulas. They're working with public health departments. They're partnering with hospitals. And so what you have is a fledgling support system for the pregnant person. In my research, what I found is that the midwives see the families as the sun, and they revolve around these families. And I think that's really important, right? In the system that I was trained in, the clinician is the sun. You have to go to the clinician, right? You have to follow their schedule. These midwives are working really hard to make sure that the family is supported. Not only whether they can provide the services for them, but they know they're connecting these families to resources in the community. Really important. As it relates to mental health, one of the things that one of my favorite moments in the research, and we talk about it in our podcast, Deep Care Podcast, was sitting in on a group visit. Amazing. You have all these families together. They're getting educated, yes, but more importantly, they are building a network of support among pregnant people, right? They are helping each other. They are making jokes. They are laughing. So for 90 minutes, they are building community. And they're doing that while they're pregnant. And that peer support continues to the postpartum period. I remember one of the clients, I was sitting in a postpartum visit, and one of the clients said, anybody know where I can get a glider? And immediately they were met with support, people wanting to help. So I think, we have the midwifery model of care, and I think it's important that we understand it's not just the midwife, that there are other people. There's a doula, uh, um, lactation specialist. There are physicians who are working with these midwives. There is the person in the community that is providing diapers. In episode 4, one of the clients said her favorite thing among, of course, getting care was that there was a big table of goodies, diapers and food, right? So when she went to the birth center, she didn't only come out with like, okay, your baby is doing well. There were groceries and diapers, and her baby wasn't even born. So that is the kind of holistic care we see midwives taking. And as we see here, you have Black women standing in the gap where our government should be, where large public institutions should be, but they're not there. And so we're standing in the gap. And one of the things that I just found amazing is how powerful this work is.
Yeah, I think you anticipated my next question, because I was going to ask you about the barriers. What is preventing, well, what would help midwife services and midwifery care become more accessible than it is? And yes, we do see that midwives are stepping in where others are not. Let's just say that, various entities, public, private, medical, otherwise. You explained to me that there is a difference as well when midwives are functioning inside of a clinical space, like how a midwife can help with the delivery and post delivery, and also work alongside medical professionals. What are you seeing as far as the ability to do that, and the need? What needs to happen so that that gets extended? What can happen that can, we need that more often?
So midwives are experts in birth, low risk birth, uncomplicated births. They are trained. And the midwives that I focused on work in the community. They're midwives who work in the hospitals. And when they work in the hospital, they work under the medical model, which is different and distinct. And often within the hospitals, they have to bow down to that model. That model supersedes their model. In the community, however, we have these midwives providing care. And so there are various things we can do today to improve access, one of which is insurance coverage. Even in states where midwives are recognized, they are licensed, few insurance companies cover midwifery care, and that has to change. The other thing that needs to happen is that in states, midwives need to be allowed to practice to the full extent of their training. Many states have restrictive laws and policies. They require midwives to have a partnership with a physician, or they require midwives to be supervised by a physician. These are restrictive practices. Now, I'm a physician, and when I saw what these midwives do, it's something different. And physicians aren't trained in that. Now, there are a handful of physicians that understand the midwifery model of care, and they partner with midwives. They respect midwives, and that is wonderful. But that is not the norm. That is the exception. So the third thing is that physicians, and I'm calling on my colleagues to be open, to educate themselves about midwifery, and to support midwifery. One of the clients said to me, here's what we need. When we go to the doctor, right, we know 90+% of people go to OBGYNs. That is the system we have. We have a fledgling system, but it cannot support all of us. When the person goes to the doctor and OBGYN, please, doctor, OBGYN, nurse, tell the person, the Black pregnant person, about all their options, including midwifery care. And so that also needs to happen. A fourth thing that needs to happen is transition between the community and the hospital. Now, midwives are experts in low risk. They're always monitoring. They have these relationships. They take, they know their clients. They have what is called continuity of care. They're spending time. So they know when something is not right. When I smell a rat or something is fishy going on here and something, we need a higher level of care. What they do and they need to do is to refer.
Yeah, I'm going to ask you to be a little more specific on that. When you say that midwives are typically low risk, you mean like when the patient is having a low risk pregnancy, everything's going,
an uncomplicated pregnancy. They don't have diseases that are uncontrolled, or they don't have some criteria. Like in some places, if you've had 3 C-sections, you're not eligible for midwifery care, or you have a seizure disorder, right? Something where you need specialty care. But let's say a low risk pregnancy, right? Your low risk pregnancy, everything is going fine. But somewhere, especially during birth, something is not right. The appropriate thing is to be referred to the hospital to be able to be monitored to get a higher level of care. The midwives that I worked with, they do that. And that is the appropriate thing. Unfortunately, when that happens, they are met with resistance, they are met with disrespect, and sometimes they are met with mistreatment.
Give an
That
example.
should stop.
Yeah, give an example of you say they're met with resistance. Who's giving the resistance?
The nurses on the floor. I mean, so clients, talked about, I mean, there was one case in particular where, the mom was having the baby delivered well, nice, healthy baby. The placenta, there was a difficulty with delivering the placenta. So the cord after the baby was born ruptured. And so the midwife picked that up and rushed the client to the hospital, right? She clamped the cord because you can imagine that's not a good thing. When they arrived at the hospital, what the client said is being mistreated. Example, she said, so that's the girl that tried to have the baby at home, right? And just a lot of disrespect. She was put in a dirty room. I mean, the things you do when, I don't even know when you do those things. Those things should never, ever happen. But these are the kinds of examples. So people are punished for wanting to have a birth outside the hospital. That should definitely end. And the last thing I will say is that all states should allow midwifery and all paths to midwifery, not just nurse midwifery and certified community midwifery, but also traditional midwifery and apprentice. We should have a really broad approach.
Most people don't understand the difference, because the difference between nurse midwifery and, you can find the midwife actually in the hospital, like you said, and the difference between the professional and I know that there are, we can share information as to which states do what. And I'm sure that there's a data center that people can call and find out, is this midwife fitting this, which category? But how would a person, since we are solutions focused, how would a person know to check out the midwife, find one, check the type, check the practice, and also how would that person complain if they get to a hospital and things are not on the up and up? What are the possibilities?
Yeah, so I think to make it simple, 3 broad categories of midwives. Now, midwifery is a field that predates nursing. It's an old field. So the nurse midwife, which is most of the midwives in the US are nurse midwives. And I was told that that's a distinction that only resides in the US, having all these distinctions. So nurse midwives are nurses first and then midwives. They go to nursing school and then they go into midwifery. And midwifery is the midwifery training they get is part of the medical establishment. So that's one category. The second category are community midwives, what are also called certified professional midwives. And these are midwives schools outside. These are community-based schools, right? They're not part of the medical establishment. And I think that is important. These are certified professional midwives. To become a certified professional midwife, you can go to school, but you can also go through an apprenticeship program where you train with a seasoned midwife, somebody who is an expert in this, somebody who's done this for 15, 20 years. And then the last category of midwife are what are called traditional midwives. And these midwives are trained apprenticeship programs, come out of apprenticeship, but they will also pay attention to really ancestral and community knowledge. So they're not focused as much as on the biomedical piece, but they're really focused on the ancestral and that community knowledge, bringing that community knowledge forward. So you can find, if you're a Black birthing person, you can find a midwife by the directory we use is called Sister Midwife. And it's a free directory. It lists midwives and doulas and other birth workers. And you can put your zip code, you can put in your state that you're in, and it gives you the information, and you call up and find a midwife. Now, we have to take responsibility for our health. So in finding a midwife, you interview the midwife, right? The midwives that I've talked to really encourage their people to interview other midwives. Call the midwife, talk to her, see what the connection is, express your concerns. Then also encourage you to bring your family, have your trusted support there with you to see, how is that feeling? Is that a good feeling with the midwife? Ask the midwife for referrals. Like, can you tell me about somebody you worked with? And I think that responsible providers should welcome the opportunity to say, yes, call X, Y, and Z. I worked with them and they'll tell you what it's like working with me. And if you have your concerns, if they are financial concerns or other concerns, be upfront with the midwife. The midwives work really closely with the clients. And I said they have payment plans. And actually, there are some institutions in some states where people subsidize. A couple of years ago in Philadelphia, there was the Feely Birth Plan. And what the Feely Birth Plan did was to subsidize the cost of midwifery care for birthing people who could not afford it. And I think there's a national organization, Birth Fund, that does that in various states around the country.
Okay. Now, thank you for that. I'm definitely going to make sure that we share information as to how people can find those organizations and ask the questions that need to be asked and do the research. Since we're coming to a close here, I want, before we don't go to audience Q&A, I want to ask each of you the same question. You've all talked about how the different types of organizations you run work with each other, but what do you think is the biggest gap between the three areas of emphasis that you all have explained in detail today? And what could better coordination look like between them? How could we get things more holistic for Black moms?
I would just start by saying, put the egos aside. We all have a role to play. That's just simply what this comes down to. Again, doing this work because of my own birthing experience, I just look at this thing differently. Because if it was a job, I would have quit a long time ago because this is hard work. It's even harder when you feel sometimes like you're fighting against each other to get things done. So in order for us to move forward, it has to be this understanding of the roles that we all play. And we should not all be doing all things. That simply doesn't make any sense, because it leads good people to no longer do the work, or good people to be so burnt out that they become a part of the problem and no longer the solution. That's just the truth. We have to start leaning into accountability for the roles that we play. That's just how I feel.
Tamara, what do you think? I saw you nodding a little bit.
Yeah, no, definitely. I agree, Kay. And I think a theme that we said, throughout this entire conversation is so simple, but the solutions are already in the community. And then all of us here, right, we're Black women, identify as Black women. And so I know at March of Dimes with Collective Impact, we talk about, the different levers that we all can pull. We all, as community members, we can pull that lever. Like, yes, we want the funding. We want the federal government to do X, Y, and Z. And we're also in a current geopolitical climate. It's not necessarily what is the word, right? Like nice, for lack of a better word, to Black folks. So while we're waiting on that to sort itself out, which we can also participate in that, a simple thing we can all do. I mentioned to you all speakers, before this call, I was participating in a virtual advocacy day. We all can advocate. Every single person. You don't have to be a mom, but we all have a mama. We all can advocate for better maternal and child health policies. So I'll drop March of Dimes' link in the chat about advocacy. You can sign up for your state. That's like a simple, concrete thing that we can do. And that's one lever that we can pull while we, that things get sorted out in our geopolitical world. But also, we are a community. We are in community. So we know what's going on in our community. So we don't have to wait for the large organizations like March of Dimes to say, I'm convening a collaborative. Like, as Kay shows, it started with Kay, right? Then you ask the next person. Then you ask the next person. And then together, collectively, putting aside our egos, how can we do this bigger, but address what's happening in our community now? Because we can't wait. Like, Black moms and babies are dying now. Like, by the time we're done with our day today, 2 babies will have died in the United States. One of those babies is Black, right? Like, that doesn't even make any sense. So that's what I say.
Thank you. Dr. Felix?
Yeah, I think for me, I want to double click on what Kay said, more coordination. There's enough. The problem is vast, and there is enough. Like this kind of competition slows us down. I also want to say, though, in addition to that, that a reframe around pregnancy, I think, is critically important. Pregnancy is not just an individual event or even a family event, it is a community event. And so we need communities becoming more responsible for pregnancy. And I didn't always think that way, but I've arrived there. So we need more communities taking responsibility for that. And related to that is really going back and reclaiming some of the ancestral knowledge that we've had. We need to go back, and midwifery is one of that ways we can do that. We go back and reclaim those, that knowledge, that way of being, that, understanding about birth, understanding about the postpartum period, mothering the mother, right? We've lost that. There was nobody. I lost my mother 4 months before I had a baby. And I was a mother. I didn't even know that that was a possibility. I did it by myself. And you have, midwives like Mama Shafia Monroe, who is bringing that knowledge back, that there is a role for all of us. Mothering is something that all of us can do, right? I was surrounded by my father and my husband. I was mothered. In any case, I was mothering. And so I think we have the opportunity with this crisis to really address it, but address it in a communal way, address it in a collective way, and tap into the collectivist mindset that is part of African descended people. We are collectivist and communal, and really tapping into those superpowers that we have.
Okay, thank you. Thank you for reminding us about the superpower of community, especially Black community. I think we are at time and ready for Q&A. Is that correct?
Yes, yes, we are. And we have lots of questions in the chat, but I want to thank you all for this conversation. As a mother, it's empowering to hear about all these resources. I wish I was able to take advantage of them, but that's why these conversations are so important. So people know and are aware of the resources that are there. So thank you for that. Question we have from Renee. Can a policy argument be made to include diapers and wipes under the WIC program for those who qualify? I feel that diapers are a basic health necessity, not a luxury item.
Can I comment on that? So we
Yes.
currently actually have a bill that we are working on. It's called the Nest Act. But the bright side of not having to wait for a bill to be passed, the Nest Act is it's already being piloted, and through the Health and Human Services Department, we have secured $5 million of appropriation for HSS to administer these diapers, wipes, this whole postpartum mom and baby care that is given to moms when they leave the hospital. It is not contingent upon how many babies you had, because sometimes, again, a barrier. But basically, what it does is it mimics what we do here at the Shades of Blue Project. So we have been able to do that. So currently, HSS gives through different hospitals. I think right now we have 20 different states that are piloting the project. You get these care packages when you leave the hospital. Again, not contingent on if it's your first baby, could be your fifth baby or your 10th baby.
Mhm.
Nevertheless, we all need help and support, but we definitely also need that help and support to make this a bill. So we're not continuously having to go back to appropriations and getting this money. It's not something that's normally done, but we have been able to do it. But nevertheless, we're definitely working to make this the standard and the norm, because as an organization who used the coupon in the beginning to get diapers, now I can buy them by the truckload. But prior to, I used to coupon to get diapers to give to moms. And right now they're $30 a case. And
Yeah.
it depends on if they have no allergies or anything else. It's just a standard box of diapers. And if it's something else, then there's also an additional cost for something else. But we are certainly working on that. Wanted to put that out there.
Thank you, Kay. And Dr. Felix, thanks for putting that link in there. So that's blackmidwifedirectory.com. So someone else asked, how do you think data infrastructure and care coordination intelligence come into play when it comes to routing community care to people in the community. Anybody want to touch on that really quickly? The role of data infrastructure, how that can help?
Does anybody want to take it? I can. Tamara, you want to do it?
Just real quick. We got a few more minutes left.
Okay, what I can say is that, of course, when the community, first of all, the community data infrastructure is just dismal, right? Data is in hospitals, it's in large institutions, and community-based organizations just don't have access to that information. However, can you imagine if we did, we would know? So we may be living in communities where they have high rates of infant mortality, high rates of maternal death, and we don't know. We don't even know what's going on in our community if it's not a personal relationship. So I think, when Tamara talks about, and I think, Kay, you were the one who talked about the coordination that needs to be among different organizations. We need data to report to be able to support that, right? Data that says, oh, our rates are this much, and the county, 3 counties away, their rates is that much. What's happening here? Let's rally the troops. Let's understand. Let's begin to experiment. Okay, we think it's mental health. Okay, you lead, and let's back you up on that. So I think that's where data plays a role to help us understand what's going on, but also when we intervene, to help us know. And although, there's a lag time between the intervention and when you see the data moving, but to help us understand whether we are moving the needle.
And so how does a current nurse, partner with midwifery initiatives and to shift into that advocacy role? So this person is saying they don't necessarily want to become a midwife, but as a current nurse, they want to support. Any recommendations?
Music to my ears. Yes. Look, go into your neighborhood. Where do you live? The hospitals that, talk. I mean, are there midwives in your hospital? Are there midwives in your community? Go into the Sister Midwifery website and look for the midwives in your city or in your state and reach out to them and tell them that you want to support. I think it's so important for nurses and physicians and OBs to really understand what the midwifery model of care is about, and to support it, to be an advocate, right? Because we are people that are part of the dominant system. We may have small roles in these organizations and feel like we are nobody, but trust me, we are in these institutions. And I think part of our role in these institutions is, one, making sure they do not harm people, really making sure, because it's very easy for harm to occur in these institutions, even without people wanting to intend that. And 2, supporting people who are innovating, who are experimenting, who are building the models of care that I believe will take us to the future.
Yes, wonderful. And so several people want to just get in contact with you all. So if we could just go around, you could give any final thoughts really quickly, and then the best way for people to reach out to you and connect. Tamara, we can start with you.
Yes, I put my email in the chat. I know which is wonderful. There have been several messages flying around in the chat, but the easiest way is to just email me at my March of Dimes address, tmason. So basically my first initial, my last name, at marchofdimes.org. I'm also very active on LinkedIn. So if you're on LinkedIn and you want to connect with me that way, please send me a connection request.
Wonderful. Kay?
Yes, our website is the best way to contact us. Those come get filtered to me, and it's shadesofblueproject.org. But if you want to send an email, it's kaym@shadesofblueproject.org. And of course, I'm on LinkedIn as K Matthews, and then we do also have a Shades of Blue Project page as well.
All right, Dr. Felix?
Yeah, so you can follow me on Instagram. Our study is at Black Birthing Futures, where we put a lot of content out about pregnancy and the solutions around pregnancy, community solutions. You can also follow me on Instagram at Kaytura Felix, my full name. And if you want to email me, 2 things. Email me at blackbirthingfutures@gmail.com or KayturaF@gmail.com. And of course, I'm on LinkedIn, but I'm not very active on LinkedIn. I'm active on Instagram. That's where the people are at.
And Jennifer, if you can talk about the series, what's coming up for you in your reporting?
I'm going to be doing a checklist for spotting danger signs, including danger signs of like what's going on with quality of care issues at your local birthing center or hospital. Also, how to recognize implicit bias by your clinician. Then I'm going to do one on spotlighting a midwife, doula, or patient relationship, and also one on economic support and maternal health. And then, of course, just in time for, around October, what the president's budget for 2027 will mean for maternal health care.
Right. Important work. Again, thank you all for this excellent conversation. Of course, you can find all of Jennifer's stories on wordandblack.com. And of course, I had to share what we have coming up for the rest of the summer as far as our events. Up next, we're talking about fast fashion. So that's your Shein and, the other clothes that you can get online. Very affordable, many of them made in China. They're cute, but they are not always the best for our health. And we're talking about maternal health today, but they're also not great for our reproductive health, right? And also the environment and Black businesses. And so we're going to dive into that conversation. That's going to be Wednesday, August 5th. And then we'll be back to our evening schedule. That'll be at 6 p.m. Eastern time. And you can, of course, register for all of them by going to wordandblack.com/events. And wordandblack.com is how you can see Jennifer's reporting. So thank you all for joining us. Once again, I'm Shernay Williams, manager with Word and Black. Thank you to our panelists. Tonight's discussion, or this afternoon's discussion, was brought to you by the Knight Foundation. Knight is a nonpartisan and community-centered organization that promotes a healthy and engaged democracy. Have a great rest of the day, everyone.